We will now reconvene the meeting to hear our updates from our CDC colleagues. We'll first have Dr. Heather Scobie present an update on emerging SARS-CoV-2 variants and COVID-19 vaccines. And then Dr. Sarah Oliver will present on considerations for booster use of COVID-19 vaccines for the future. So Dr. Scobie.
Good afternoon. Next slide. Next slide. This slide shows one of the new ways that CDC is visualizing the impact of COVID vaccination on the COVID data tracker website. The graphs display weekly trends by age group for the cumulative percent of people fully vaccinated in blue and the average rate of new cases per 100,000 population in gray. The three graphs at the bottom in the red box represent the three age groups greater than 50 years of age. Here we observe higher coverage rates and lower case rates compared with the younger age groups shown above that have lower coverage and recent increases in cases. Next slide. This map, also from COVID Data Tracker, shows a county-level view of the case rates per 100,000 population over the past 7 days compared with vaccination coverage rates. A legend is shown on the right. The magenta and purple colors that predominate the map are counties with low vaccination coverage and high recent COVID incidence. The green and light blue colors are counties with higher coverage and low COVID incidence. Counties colored navy blue, which represents greater than 50% coverage and high incidence, are relatively few and reflect the recent increases in Delta variant transmission occurring largely among unvaccinated persons. Next slide. A lot of public concern has been raised on the Delta variant and breakthrough transmission, which I'd like to try and contextualize with two example state scenarios, each with 1 million population and different coverage levels. State A has 70% coverage on the left, and State B has 30% coverage on the right. The COVID data used for this example are actual data from the COVID Data Tracker website for states with similar coverage levels. The dots each represent 10 COVID cases, and in State A, 130 cases are occurring per week, compared with over 5,000 cases occurring weekly in State B. Using the vaccine efficacy estimates from the UK, we can estimate the number and proportion of vaccinated cases shown in red and vaccinated cases shown in blue. Proportionally, there are more vaccinated cases in State A at 22% of cases vaccinated, compared with just 5% in State B. But this is expected because the proportion of cases vaccinated increases with increasing vaccination coverage. At the extreme of 100% vaccination coverage, all cases would be vaccinated because no vaccine is 100% effective. Next slide. Similar trends with hospitalization are observed below, where 1 dot equals 1 hospitalization. In State A, just 1.4 hospitalizations occur weekly, and in State B, 18.8 hospitalizations occur. In both states, the majority of cases and hospitalizations are among unvaccinated people. Next slide. Next slide. 4 variants are considered variants of concern. Alpha or B117 first detected in the UK, Beta or B1351 first detected in South Africa, Gamma or P1 first detected in Brazil and Japan, and finally Delta or B1617.2 first detected in India. Attributes of the variants related to public health impact are noted in the table. Of note, all of the variants of concern have mutations in the receptor binding domain that have variably impacted vaccine efficacy, with the cluster of mutations shared by Beta and Gamma having the largest known impact. Another class of variants under monitoring are the variants of interest, which have similar mutations but less current evidence of public health impact. Next slide. These are our latest national nowcast projections of the proportions of circulating SARS-CoV-2 variants from CDC's COVID Data Tracker. The stacked bars show the observed historic estimates and the most recent nowcast projections for the commonly sequenced SARS-CoV-2 lineages in the US by 2-week interval of specimen collection date. The variants of concern depicted in different orange shades have increased over time. In projections for the 2 weeks ending July 31st, alpha decreased to a projected prevalence of 2%. Gamma decreased to 1% and beta remained at 0%, while the Delta variant increased to 94%. Recently, the graph was changed to display the different Delta sublineages, and AY3 has increased to 13%. This sublineage does not contain the so-called Delta plus mutation. Next slide. We have several types of evidence that we monitor to assess the impact of variants on vaccines, including antibody neutralization generated in the laboratory. Though we note that a correlate of protection is not yet established, good correlation has been observed between vaccine efficacy and the neutralizing antibody levels from different vaccines, and this will likely be the first type of evidence we get on the impact of new variants on vaccines. We also monitor vaccine efficacy data from clinical trials and real-world vaccine effectiveness studies. We note that a greater proportion is usually observed against severe disease, or greater protection is usually observed against severe disease than symptomatic illness, and confirmed infection, which includes asymptomatic cases. And this is because protection against severe disease requires lower antibody levels and is less affected by differences in efficacy across vaccines. Finally, we monitor vaccine breakthrough infection, and I'm going to review these types of evidence now. Next slide. We conduct a review of available studies on vaccines authorized or intending to be authorized in the US and containing data on the ability of post-vaccination sera to neutralize SARS-CoV-2 variants. In this dot plot, the reduction in neutralization of the variants is shown relative to the wild type or dominant strain used in each study, where no effect equals 1 at the bottom of the y-axis. Each dot represents one study result, with mRNA results shown together in blue, AstraZeneca in yellow, Novavax in brown, and Janssen in green. Beta had the largest median reduction at 7.5-fold, Delta had a median reduction of 2.8-fold, Gamma was reduced 3.1-fold, and Alpha was reduced 1.9-fold. While an Alpha variant with an E484K change, which has been detected in the UK, US, and other countries, had a further reduction in neutralization compared to Alpha alone. Next slide. In terms of what is known about duration of immunity, to date, available data demonstrate antibody persistence for at least 8 months after COVID infection and at least 6 months after the second mRNA vaccine dose, with some evidence at 8 months for the Janssen vaccine. Studies suggest individuals may maintain long-term protection from severe illness caused by antigenically similar strains, even if they become susceptible to mild infection. 2 studies have shown a combined impact of waning antibody levels and reduced neutralization of variants. At 6 months after receiving the Moderna vaccine, neutralizing antibody levels were reduced but sufficient to protect against the ancestral strain, while about 50% of people had undetectable neutralizing titers against the beta and gamma variants. A small study at 8 months after receipt of the Janssen vaccine observed minimal decline in neutralizing titers and improved protection against beta, gamma, and delta variants compared with 1 month after vaccination, which was suggested to be related to antibody maturation. It's unclear if there are differences in the kinetics of antibody response by vaccine platform, and more data is needed. Next slide. Pfizer recently published their 6-month clinical efficacy data. Vaccine efficacy, or VE, against infection out to 6 months was 91%. They performed an additional analysis looking at different time intervals after receiving the second vaccine dose and observed a gradual decline in VE against infection of 6 percentage points every 2 months, though the confidence intervals around the estimates were overlapping. At 4 to 6 months post-vaccination, VE was 84% compared with 96% at less than 2 months after vaccination. VE against severe illness during the period was 97%. Moderna has not yet published their extended efficacy results, but announced in a press release that VE was 93% for up to 6 months. Next slide. In terms of VE against the variants, for the Alpha variant, mRNA vaccines have been shown to have greater than 85% real-world VE against confirmed infection in the US and multiple countries. For gamma, mRNA vaccines had 84% to 88% real-world VE against symptomatic infection and 79% VE against confirmed infection when gamma was widely circulating in Canada. For beta, Moderna vaccine had 96% real-world VE, and Pfizer vaccine had 75% VE against confirmed infection in a study from Qatar, while Janssen vaccine had 52% VE against moderate or severe disease in their clinical trial in South Africa. Importantly, all studies observed high VE against severe disease. Next slide. In terms of what we know about the Delta variant, it's nearly twice as contagious as previous variants. There is some evidence of increased illness severity compared with previous strains in unvaccinated persons. The greatest risk of transmission is still among unvaccinated people, and fully vaccinated people with Delta breakthrough infections can spread virus to others. However, when vaccinated people with Delta may be infectious for shorter periods than unvaccinated persons with Delta. Next slide. For the Delta variant, vaccine effectiveness studies have been published from several countries, mostly for the Pfizer vaccine. In England and Scotland, reduced Pfizer VE was observed at 79% for infection and 88% for illness compared to 92 and 93% for the Alpha variant. Protection against hospitalization from Delta was 96%, which was similar to that observed with Alpha. In Canada, Delta VE estimates were similar to the UK, but with smaller differences in VE for Alpha and Delta. Israel has observed a progressive decline in VE during the period after Delta predominance, with the most recent VE estimates of around 40% against infection and illness, while VE against severe disease has remained above 90%. Qatar was the only country that assessed Delta VE for both Pfizer and Moderna, shown with hollow symbols. VE against symptomatic illness was 54% for Pfizer, compared with 85% for the Moderna vaccine, while VEs against severe illness were above 90% for both. It's important to note that the comparisons shown for the Alpha and Delta VE in Israel and Qatar are for different studies that were separated by 2 to 5 months during the time periods when Alpha and Delta circulated. Other methodologic differences may explain some of the variation observed in the study results across countries. Next slide. Other potential differences in VE results relate to differences in the vaccine programs by country. In the US, we use the Pfizer, Moderna, and Janssen vaccines, which have followed the manufacturer-recommended intervals of 3 and 4 weeks between mRNA doses. Israel has also used Pfizer vaccine, and has only used Pfizer vaccine, though they also authorized Moderna, and followed the 3-week interval between doses. Israel also had a very tight cohort with more than 50% of the country vaccinated in the first 3 to 4 months. Qatar is the most similar country to the US in terms of using both Moderna and Pfizer at the same dosing intervals. Finally, the UK and Canada are the most similar to each other in that they both use mRNA and the AstraZeneca vaccines. As part of a dose-sparing strategy, they also adopted extended dose intervals of up to 12 to 16 weeks, which were later shown to improve immunogenicity and VE compared with standard intervals, including for ages greater than 80 years. The countries also support mixing and matching between vaccines, which has been shown to increase VE. I'll also note that the Pfizer vaccine has a lower mRNA dosage, an accelerated schedule of 3 weeks compared to 4 weeks for Moderna, which has the potential to impact the robustness and duration of immunity, as has been generally observed for other vaccines. Next slide. In public data from Israel, the Ministry of Health has observed higher breakthrough rates and lower Pfizer VE against infection for persons vaccinated during January to February than in more recent months for persons aged 16 to 59 and 60 years and older. 2 retrospective cohort studies of persons vaccinated with Pfizer in large healthcare systems observed increasing breakthrough infections among persons vaccinated in January versus April, and higher breakthrough infection rates among those who received the second mRNA dose, more than 5 months ago compared with less than 5 months ago. All age groups were impacted, but one study observed higher magnitude of differences with increasing age. Next slide. Delta only rose to predominance in the US at the end of June. This week, the first study assessing potential VE changes in July was posted from the Mayo Clinic healthcare system. For patients in Minnesota, the authors observed that VE against infection was significantly lower for both Moderna and Pfizer vaccines in July, when Delta variant was more than 70% prevalent compared with previous months, and significantly lower for Pfizer at 42% compared with Moderna at 76%. Importantly, the effectiveness of both vaccines against COVID-associated hospitalization remained consistently high during the same time frame. More information is needed in this area and will be forthcoming. Next slide. Despite high efficacy, vaccine breakthrough cases are still expected to occur, including those caused by circulating variants. CDC conducts nationwide monitoring of vaccine breakthrough cases resulting in hospitalization or death. As of August 2nd, among more than 164 million fully vaccinated in the US, there have been 7,101 hospitalizations and 1,507 deaths, with vaccine breakthrough reported to passive surveillance. Among hospitalized or fatal breakthrough cases, 75% were 65 years or older. In addition to national passive surveillance, CDC has a number of other ways to monitor breakthrough infection, including a population-based surveillance system called COVIDNet, which represents 10% of the US population. The most recent COVIDNet data on COVID-associated hospitalizations among adults estimated 32% of all vaccinated cases are immunocompromised versus 11% of unvaccinated cases. Next slide. To summarize, alpha, beta, and gamma variant have low prevalence in the US. Alpha has minimal impact on VE, while beta and gamma have moderate impact, though the vaccines appear likely to protect against severe disease. Delta has high prevalence in the US and has moderate impact on vaccine effectiveness, though the vaccines are likely to still provide protection against severe disease. More data is still needed on the impact of Delta, especially for the Janssen vaccine and the potential for waning immunity. Next slide. Manufacturers are conducting booster studies of current vaccines and/or second-generation vaccines against the beta variant. Moderna has posted a preliminary results of the phase 2 trial of a single booster dose of the previously authorized and a beta variant-specific vaccine. Both vaccines had acceptable safety and boosted immunity to the wild-type strain as well as to the beta and gamma variants. Pfizer has also submitted preliminary data on a booster of their original vaccine to the FDA. No Delta-specific booster vaccines have been shared to date, or studies have been shared to date. In summary, next slide. In summary, the currently authorized vaccines work against known variants. Given the increased risks related to the Delta variant, it is important to increase vaccine uptake in all eligible populations. CDC is closely monitoring real-world vaccine effectiveness and breakthrough infections using multiple methods, populations, and outcomes. CDC continues to monitor emerging variants, including their prevalence and impact on disease incidence, severity, and vaccine breakthrough. The ACIP will review evidence submitted for boosters and any next-generation vaccines to address the evidence of diminished VE related to the variants or waning immunity. Finally, this is a changing landscape, and CDC will continue to communicate promptly about emerging evidence. Thank you.
Thank you, Dr. Scobie. And this presentation is now open for questions. Ms. Bata.
Thank you. And thank you for this thorough presentation. I really appreciate the information you've provided today. I'm wondering if we could go to slide 20. I think I need some clarification about the last bullet, that 32% of all vaccinated cases are immunocompromised versus 11% of unvaccinated who are immunocompromised? Can you please explain that to me?
Sure. It means that by vaccination status, there are differences in the way the cases look, I guess. So just like breakthrough cases, fatal breakthrough cases, would occur in older persons, as is summarized. For immunocompromised people, there's a larger proportion for breakthrough cases, there's a larger proportion of immunocompromised persons compared with unvaccinated cases. I'm not sure if that's clear, but there are differences in the background characteristics of cases that are vaccinated versus those that are unvaccinated. Is that clear?
Thank you.
Thank you. Dr. Arthur?
Thank you, Dr. Lee. I really liked the slide at the beginning that shows the variation in ages and immunization rates by age and how that's affecting the case counts by age. I wondered if the CDC had intended to do the same analysis by race and ethnicity. I think that in terms of understanding the overlapping pockets of unvaccinated persons, the age category is just one part of the problem, and understanding how race and ethnicity are affecting both vaccination levels and case count would be extremely helpful. I think that was a great slide. I'd love to see it broken down by a couple of other factors. Yes, this slide here. Thank you.
Thank you.
Thank you. No, our CDC colleagues will take that under advisement. Dr. Freihofer?
Sandra Freihofer, American Medical Association. Thank you for that excellent presentation. Could you take a look at slide 9? You briefly mentioned the Delta Plus variant, but I sort of missed what you said, and this is something I get a lot of questions about.
Sure. So
the Delta Plus variant.
The Delta Plus variant, it's not a name we actually use, but it does correspond to what you see as AY1 and AY2 on this slide. So AY3 does not have the mutation that the media refers to as Delta Plus. Is that clear?
Thank you so much. And on slide 16, can you say again what the open circle meant under the Qatar? It's an open blue circle.
Yeah, so do you see the bands under the country labels for Pfizer and Moderna? This slide was hard to create without making it look overly busy, so only the 2 results on the right relate to Moderna. The rest relate to Pfizer. And that's...
Thank you so much.
Thank you. Dr. Maldonado?
Yes, thank you. That was a great presentation. I have a question about the Mayo study. I have reviewed the manuscript, the preprint, but I'm still a little confused about the statistical methods that were used to calculate effectiveness, and I wondered if you could provide some clarity. They used an interesting approach, which is they used matched triples, so an unvaccinated, vaccinated with Pfizer, and vaccinated with Moderna. But the thing that I'm concerned about, or at least want more your input on, is they actually included people who would receive, their whole cohort included single vaccinations as well as fully vaccinated individuals. But I couldn't really determine whether they calculated effectiveness based on breakthrough infections after all 1 or more doses or just after 2 doses. And that, I think, would affect effectiveness. I don't know why it would skew by product, but certainly that could affect effectiveness as well. So just wondered if you have any additional information about whether they, in fact, included just fully vaccinated or not. It looks like they included all, even single-dose vaccinated individuals.
Thanks. So that paper is still, it's a preprint. It's still under peer review. So let's hope that if it's not clear, it's clarified for the final publication. I don't have any additional information beyond what's included in the preprint. And we're looking forward to results that should be released from CDC studies in the coming weeks.
Thank you. Ms. Leger?
Hi, thank you. Thank you for your presentation. On slide 12, addressing duration of immunity, do you have any data about individuals who've had the vaccine and COVID-19 infection as far as how long their immunity antibody persistence lasted? I guess the question is your immunity additive if you've had both natural infection and vaccine?
Yeah, thank you. There are quite a few studies published on this topic, and the consensus appears to be that having a previous infection and then being vaccinated probably provides the best immunity compared to just getting just being infected or just being vaccinated. It boosts immunity levels to high levels and has greater protection against variants because of maturation of the immune response. But I'm not sure about the duration of protection and whether there's information available on those individuals related to the question you asked.
Thank you.
Thank you. I see no new questions, so I wonder if we can move on to Dr. Oliver's presentation.
Great, thank you so much. Next slide. So as we think through recommendations for booster doses of COVID-19 vaccines, the main question we're answering is, are booster doses needed for those previously vaccinated with the primary series? As with other things with COVID vaccines, policies on boosters will be coordinated with FDA for regulatory allowance and ACIP for recommendations around use in specific populations. Next slide. Then we want to continue to distinguish that an additional COVID-19 dose after receipt of a primary series is one way to provide protection for those who may not have mounted an appropriate immune response to the initially recommended series. This is not considered a booster dose, and this is what was described for the first part of the meeting. What we're talking about now are booster doses, which are vaccine doses administered when the initial sufficient immune response to a primary series may have waned over time after a primary series and then can increase immunity. Next slide. So from this point on in the presentation, we'll be focusing on booster doses. Next slide. So recommendations for booster doses would obviously only apply to those who have completed a primary series. To date, over 350 million vaccine doses have been administered in the US. The figure on the left shows the number of people fully vaccinated by COVID vaccine series type. Then on the right shows percent of the population fully vaccinated by age. Over 60% of those 18 years of age and over are fully vaccinated, and this increases to over 80% among those 65 years of age and over. Next slide. So the timing of when individuals became fully vaccinated is important to this discussion as well. This figure shows the daily count of fully vaccinated people with the 7-day moving average shown in red. As everyone will recall, we began the COVID vaccination program in December of 2020. As only 2-dose series were available at that time, we began to see individuals become fully vaccinated in January. Then through spring, we increased vaccination rates, where between 1 and 2 million individuals were fully vaccinated each day. Then through the past month, we've been adding around 200,000 fully vaccinated individuals each day. Next slide. However, we know that due to the way the vaccine was recommended and rolled out initially, age groups are not evenly distributed across the last 8 months. When we look at the weekly count of fully vaccinated people in the US by age group, you can see that those 65 years of age and over in yellow were among the earliest vaccinated. In the spring, we then moved into larger populations of those 18 to 39 in lavender and 40 to 64 in gray. And then recently, since vaccination was recommended for adolescents, you can see the 12 to 17-year-old population in black. This varying age distribution will be important as we think through recommendations for boosters in a variety of populations and ages. Next slide. So this is the plan for how ACIP will approach booster doses over the next several weeks. We need to think through what are the key considerations for decision making. Then we evaluate what data are available for decision making. And finally, then we can address, does ACIP recommend booster doses for COVID vaccines in any populations? Next slide. For today's presentation, we'll focus on what are the key considerations for decision making. Next slide. At the ACIP meeting in June, we laid out data that would be needed to inform recommendations for booster doses, thinking through the risk of COVID complications and exposures, risk of waning immunity, and risk of COVID variants. Next slide. As we move into preparations for a possible vote in the future, we're restructuring the questions slightly, thinking through these two main questions we need to address booster doses. Do we need them, and do they work? We can take these questions to think through using aspects of our evidence to recommendation framework. To answer, do we need them, we'll think through the public health problem of COVID and what information we have on the current vaccines. Then, do they work? We will think through the benefits and possible harms of booster doses of COVID vaccines. Next slide. So under the public health problem, we'll need to specifically address, is vaccine effectiveness, or VE, waning over time? Is VE reduced for the Delta variant? And does this data vary by subpopulation? Under benefits and harms, we'll need to address if booster doses of COVID vaccines are safe and immunogenic. Will booster doses of COVID vaccines reduce COVID incidence, hospitalization, and mortality? And do booster doses improve VE against the Delta variant? We'll walk through each of these questions in more detail, outlining data we'll be collecting to address these overall questions. Next slide. First, is VE waning over time? Specifically, we need to assess if VE at 6 to 8 months is similar to what was noted at 2 months after vaccination that ACIP reviewed at the time of the EUA. And how does this data vary by severity of disease? We may see that VE wanes for asymptomatic or mild disease, but remains high for severe disease, hospitalization, and death. And what data on waning VE would identify a need for booster doses of COVID vaccines? Next slide. So the next is VE reduced for the Delta variant. And again, how does this vary by severity of disease? And while the Delta variant is clearly what we're dealing with right now, how would this information on Delta variant impact VE for future variants? Next slide. And finally, for the public health problem, the final question for the public health problem, does this data vary by subpopulation? At previous ACIP meetings, we've discussed that boosters may be recommended for the entire population, or they could only be needed among specific subpopulations. Groups identified as needed close monitoring and additional data collection include residents of long-term care facilities, adults 65 years of age and over, and healthcare personnel. Next slide. For long-term care facility residents and older adults, we've already highlighted that these were vaccinated in the earlier phases of the COVID-19 vaccine rollout. In addition, this is a population that has needed special considerations for other vaccines, including additional boosters or higher dose vaccines. In addition, healthcare personnel were vaccinated in the early phase of the vaccine rollout. They will have continued exposure to SARS-CoV-2. And another point that was not mentioned at a previous meeting, but clearly could be an issue in the future, there could be a need for additional considerations for healthcare personnel to include the continuity of healthcare systems. We may have a very specific need to prevent asymptomatic or mild infections in healthcare personnel if there are COVID surges straining healthcare infrastructure. Next slide. So next, moving to the benefits and harms. We need to address if booster doses of COVID vaccines are safe and immunogenic. Assuring COVID vaccine safety has been a critical of the entire COVID vaccine program and will continue into this phase as well. We need to know if COVID vaccines provide a boost in neutralizing antibody response. And while we're likely to get this information, we also need to address how neutralizing antibodies correlate to clinical protection from COVID-19. Next slide. We need to evaluate if booster doses of COVID vaccines will reduce COVID incidence, hospitalization, and mortality. We're not likely to have long-term efficacy studies with booster doses, but need to think through other ways to address if booster doses will reduce COVID morbidity and mortality. Next slide. Then, do booster doses improve VE against the Delta variant and other variants of concern? Again, Delta is what we're focused on now, but it's unlikely to be the only variant we'll have to address in the future. What do we know about boosters and other known variants of concern? And how can this data inform VE for future variants? Next slide. So now highlighting the workgroup interpretation of these considerations and the framework around booster doses. First, for their thoughts around the public health problem. Right now, the largest public health impact will continue to be from individuals receiving the COVID vaccine primary series. We know that the vast majority of cases, especially cases requiring medical attention now, are in unvaccinated individuals. The best way to address the current surge we're experiencing is for individuals to receive the primary series that is currently recommended and available. Then, decisions for boosters need to focus on the prevention of severe disease, hospitalization, and death. And the work group strongly emphasized the importance of ensuring global vaccine availability. New variants could emerge from regions with low vaccine coverage and high community transmissions. One of the best ways to protect the population here from the next variant threat is to ensure that the remainder of the global population has access to a safe and effective COVID vaccine. Next slide. Next, the workgroup interpretation of the benefits and harms. Neutralizing antibody data will be important for booster dose discussions, but may not represent the entire immune response to COVID vaccines. We can't make decisions around boosters based solely on detectable neutralizing antibodies. The cellular immune response can be difficult to measure in a broad population, but is important in our ability to fight COVID. And commercial antibody testing is not authorized or recommended to evaluate post-vaccination immune response. Based on available data and the timing of vaccine rollout, the initial booster vaccine policy will be focused on the at-risk adult population. Adolescents are only just now receiving their primary series. The at-risk individuals we've highlighted that we'll focus on include adults 65 years of age and over, long-term care facility residents, and healthcare personnel. Next slide. So going back to our roadmap for booster doses, today we've discussed key considerations for decision-making. Next slide. The plan now is to have another ACIP meeting in the next several weeks where we'll fill in this framework and identify what data are available for decision-making. Then, once we've evaluated the available data and have regulatory allowance for booster doses, we can address if ACIP recommends booster doses of COVID vaccines in any populations. Next slide. I do want to highlight that there will be some questions we may not have the amount of data desired as we move into these decisions. We may not have detailed information around how VE varies for each specific COVID vaccine in each specific subpopulation. We may not know VE for booster doses of COVID vaccines, especially in each subpopulation. And finally, we won't know how the need for booster doses of COVID vaccines evolve as the pandemic evolves. However, by continuing to present and discuss the available data at public ACIP meetings, we can highlight what we know and don't know, and how that information can inform possible future recommendations. Next slide. I want to thank the mighty team listed here that's helped with the many things our COVID ACIP team is working on that you see and don't see, as well as the Vaccine and Epi Task Force and Respiratory Viruses branch here at CDC. Next slide. So our questions posed to ACIP today is, does ACIP agree with the framework laid out to address booster dose recommendations and the workgroup interpretations? And are there other questions that would be important for ACIP to address? Thanks.
Thank you so much, Dr. Oliver. That was an excellent presentation as always, and a clear delineation of the issues at hand. I want to ask, are there any ACIP members who have any questions that they'd like to ask? Dr. Talbot.
I actually have two. I think one of the important things for us to define are how many, or to define the number of areas in the U.S. with low vaccination rates. Giving a third dose to people who are already willing to get a vaccine and to mask may not overcome the large pockets of unvaccination. And so I think
Dr. Talbot? We can't hear you. Dr. Lee, can you hear us?
The comments and the questions. I'm hoping they can hear us, and then at the end we can capture all the comments and have a discussion about those.
Dr. Lee, just to give you an update. You're back.
Dr. Virginia Kane with the National Medical Association. Are we also looking at my concern for boosters related to chronic medical underlying conditions such as diabetes in our patients where they may be immunocompromised? And we know the durations of our vaccines based on your studies you just showed about 8 months. But does the Delta variant create any issues for the longevity of our immunity related to the effectiveness of this booster immunization? So I'm very concerned that it may be a different efficacy depending on race and the type of chronic underlying medical condition compared to our majority population. And I really emphasize this, that when you look at African Americans, Latino ex-populations, Native Americans, we are almost 3 times the rate of hospitalizations. Our death rates are over twice as great as our white counterparts. So I'm very concerned about making sure that we're doing those booster dose recommendations that's really required for our populations that may have a higher rate of some mild immunocompromise that doesn't merit the rank of being a transplant or a advanced treated HIV, but a significant populations of a lot of chronic medical conditions that can impact us.
Okay, thank you so much, Dr. Kane. There's a couple more questions in the chat. I see that our CDC colleagues are back on. May I ask if you were able to hear the questions or the comments, or if you missed them?
Hi, Dr. Lee, this is Dr. Oliver. Can you hear me?
We can, yes.
Okay, great. We dropped out through Dr. Talbot's questions, and then we heard what Dr. Kane said. So I don't know what was in between. But we're happy to follow up and have individuals on our team that were taking notes as well.
Okay, terrific. I think I'm just going to jump in for 1 second, this time as a member, and comment quickly about a couple of themes that I had heard and also my own questions. which are, I think, better correlates of immunity are sorely needed. We actually all understand that. I think it would be really helpful to understand of the gaps in the data that are currently existing, what's being pursued by the companies and or FDA as standards for immunity and or NIH to better understand it. Any information, I recognize that a lot of this won't necessarily sit within CDC, but it seems like we need that strong partnership to better define what the correlates of immunity are. The context of the unvaccinated can't be forgotten in the silo of this particular question, which I know you all recognize, but I think that was emphasized again. Individuals living in congregate living facilities, I'll just add that as a particular topic. And then this question about chronic medical conditions and race ethnicity, I think this reminds me of the conversations we had when we were talking about designing those clinical trials and ensuring that there are diverse populations included to demonstrate efficacy and safety, and just how important it is for us not to forget that continues to be important in the effectiveness and post-market safety phase, and that we need to continue to pay attention to any meaningful differences. And some of that is already in what you're doing with understanding risk by different conditions. But I think also just for us as ACIP to remind ourselves that we can't ever forget how important to continue that attention on ensuring that the benefits and the risks are, for everyone. Okay, I'm going to pause there. Dr. Oliver, is there anything you want to respond to in the very short term before I move on to additional questions?
No, thank you. Just the noted and taking notes. I think we are aware of those gaps as well, and we'll hope to fill them in with future presentations, but taking notes. Thanks.
Thank you. Dr. Maldonado.
Yeah, thank you very much for laying out the framework for consideration in future policy decisions. But I want to make 2 points. The first is that we're well beyond a year now when these clinical trials started and these many thousands of individuals submitted to really exciting opportunities, but also provided blood samples and lots of detailed follow-up. And I really think that the companies really owe it to the public health infrastructure of the U.S. and elsewhere to really find those data. I mean, it's been a year. We know that breakthrough cases happened. We know there's blood samples that were available. We should be able to identify at least some level of correlation between immune markers. Hello? Sorry. Anyway, correlation between immune markers and breakthrough cases versus not. I mean, that's not hard science. I mean, that's pretty straightforward. And I think the data should be there because the samples are there and the patients are there. So we really need to hold these groups accountable, given that many thousands of people volunteered, put blood in these biobanks, and they are available now. We should be seeing these data. So I really call on transparency on that. And an immune correlate is critical at this point, and there's no reason why we shouldn't start to at least understand and know what we understand and what we don't. The second thing I want to point out is, again, relative to children, that let's not wait until we finish one set of studies before we start tacking on more studies. It takes more time to do that, and why not plan ahead with the children that we have now, like you have done with adults, so that we can enroll all the children we need up front and make sure that we do booster work with them too, if that is appropriate. But adding them on at the end is highly inefficient. It's not fair to the families, and it is really an obstacle for us to getting long-term data on children that we also need. So those are just 2 call to actions, if you will. Thanks.
Thank you, Dr. Maldonado. Dr. Zahn?
Yes, thank you, Dr. Lee. Just a comment is, I think it's going to be really important to be messaging appropriately about ACIP's deliberations. It seems like to me, as of today, officially, the ACIP is considering the need for a booster dose. But to my mind, from what I see from epidemiology in my community, I think around the country, I think we have very little evidence at this point that waning immunity, is a significant driver of burden disease right now. Right now, the overwhelming driver of disease, serious disease in particular, is people who are unvaccinated. And I think the CDC's, the ACIP's cadence of meetings for this, which is going to happen over several weeks, and obviously the FDA deliberations are going to be important as well, reflects, I think that reality. But I think that if epidemiologic data or the facts on the ground change, then ACIP and the FDA will change accordingly in terms of their assessment of the situation, to more promptly, provide guidance as needed. But I guess my point is that right now it seems like this conversation is anticipating the potential need over time to give a booster dose, as opposed to there's evidence that people need a booster dose right now, and the ACIP is just looking through the data. And I just think that that's an important distinction. That's going to be important to communicate that to the general public and to providers.
Thank you, Dr. Zahn. Are there any other questions or comments? Okay.
Dr. Lee, I don't see any other comments. I know that this is the first of many discussions, and we do anticipate a part of the reason for us to have multiple meetings over the next several weeks is, as this data emerges, we wanted people to start thinking and be prepared to address it. If you are ready, we can go ahead and close this meeting, or do you have any final comments?
Well, I just want to thank all of our presenters for leading these robust discussions on the topics, most recently of variants and boosters, but also for the vote on immunocompromised. I think it was a really productive meeting today. I'll look to my ACIP members to see if there are any last comments or suggestions that they might have. Okay. Well, hearing and seeing no additional hands raised, and given that we are running late, I will now be very happy to adjourn our meeting today, and thank everyone for your participation and your engagement. Dr. Cohn, is there anything else?
That is it. This concludes the meeting after you officially conclude it, and we be on the lookout for information about a meeting on August 24th or any potential changes, and we appreciate everyone's time today.
Thank you. The meeting's now adjourned. Everyone have a great day. Take care.
Thanks.